The original title for this talk was supposed to be Basal Ganglia Anatomy and Circuitry, and it's meant as a prelude to the next several talks that you'll get in the functional neurosurgery domain, in which we'll have many of our movement disorder neurologists come and speak to you about the medical and surgical management of all the movement disorders, but particularly tremor, dystonia, and Parkinson's disease. And so what I thought I'd give you is not just a basal ganglia lecture, but also the thalamus, which are, the thalamus is not part of the basal ganglia, and we'll talk about the formal definitions. But talk about this, touch a little bit on the diseases that we treat and the anatomy as it's relevant to those diseases, and hopefully use this as a launching ground for the subsequent talks. So there's no disclosures at this point. And so the objectives and outline for the talk, really I've divided into two parts. The first part is, as I mentioned, we'll discuss basal ganglia. The second part is the thalamus. And in each case, what I'll do is try and define the terminology. What exactly does the basal ganglia encompass? Review the anatomy. And anatomy is, it's interesting. Depending on your perspective, you can look at anatomy in many different ways. You can look at anatomy in an atlas, which is historically how we've done it in neurosurgery. And I think that history comes from the fact that we used to not really have good neuroimaging techniques that could actually show us the anatomy. So, for example, functional neurosurgery used to be done largely based on ventriculography. So that's why we needed atlases, because the AC, anterior commissure and posterior commissure, were the only landmarks we could really identify. So we reviewed that very briefly. Anatomical MR imaging, so actually looking at anatomic structures, and then a little bit more familiar to us in the clinical environment, using microelectrode-guided techniques to define anatomy and stimulation-guided techniques. Finally, to discuss connectivity. And I think despite the emphasis in medical school and when you're first learning anatomy as a resident on structures, particularly in the treatment of movement disorders and in the whole field of neuromodulation, we're really moving away from this concept of anatomy as single targets or single structures as targets, and we're really modulating networks. So understanding the connectivity and how everything influences each other is really critical. Starting with the basal ganglia, and perhaps the most relevant place to start a discussion of the basal ganglia is what exactly is included in the basal ganglia, and this is what most people include in the basal ganglia. So striatum, as we know, is the caudate and putamen, and the ventral striatum is, the striatum can be divided into two parts, the dorsal and ventral. And the dorsal striatum is what we're most often referred to as the caudate and putamen. But then the ventral striatum, where those two nuclei join together in the nucleus accumbens and the olfactory tubercle. Likewise, the globus pallidus, we're very used to talking about the GPE and GPI, globus pallidus externus and internus, which is really the dorsal pallidum. But there's also a ventral pallidum near the anterior perforated substance, which we refer to grossly. But the globus pallidus also has different segments to it that we don't really think about clinically, but that do exist. The two other structures which we talk about often are the subthalamic nucleus, which will define the anatomy of, and the substantia nigra. More recently, there's been some interest in trying to include two additional nuclei within this overview of basal ganglia within the catchment area of basal ganglia, one being the peripontine nucleus, or the PPN, and as well the nucleus within the thalamus, which the name just escapes me right now, but we'll get to it in a little bit. Centromedian nucleus, thank you. Oh boy. So, this is not working, unfortunately, on there. So, that's what I'll show you on that presentation. So, I put that up, and I think one of my main points is we are so used to looking at anatomy in cross-section, and I think it's really important to understand that these structures are not cross-sectional, they're not isolated structures. they actually all relate to one another in a somewhat a circumventricular fashion, especially the caudate, obviously. And the caudate really, even though we look at the basal ganglia primarily deep to the insula, the caudate extends all the way down into the temporal horn of the lateral ventricle. So it's important to remember how all these structures interrelate with one another. So besides the basal ganglia, there's other structures that are really critical and intimately related with these. The thalamus being one, and we'll talk about that extensively, but also this concept of the Forel's fields, which are white matter tracts that are running immediately inferior to the thalamus around the subthalamic nucleus and really connect many of these critical parts of the basal ganglia networks. And then the zona incerta, which is again in that same region around the Forel's fields, just superior. Okay, so as I mentioned, there's multiple means of delineating anatomy, whether we're approaching it from an atlas standpoint, anatomical standpoint, microelectrode standpoint, and I'll try and give each one and my thoughts on each one. So first I wanted to talk about the striatum and globus pallidus, and really the only target the only structure we target neurosurgically within the striatum globus pallidus is going to be the globus pallidus, and there are different. Really, we rely on the Schultz-Graham-Warren atlas, and these are the coordinates that you look for to get to the globus pallidus internus. And as you can see, it doesn't really mean much to just have these numbers, and that's why I think using these numbers is a really good starting point. But really, what you have to do is understand the anatomy and as it relates to everything around it. And once you understand the adjacent structures, that'll give you some a better appreciation of how it connects to other things and what the limiting structures are. So if we look at the globus pallidus, of course it sits just internal to the putamen as part of the lentiform nucleus, and there's a globus pallidus externus and globus pallidus internus. So the first structure I want to really point out is obviously internal capsule, which forms the medial aspect or medial delineation of the globus pallidus, and also runs between the caudate and putamen within the dorsal striatum. What you should appreciate is that these aren't completely separate structures, and there are gray stria that connect the caudate and putamen, and they're called the caudata lenticular gray stria. And that's important to know because as you do recordings, and we'll talk about recordings later, but if you pass an electrode, a microelectrode, through that internal capsule, which should be completely silent because there should be no firing cells, you may hit some of those gray stria and might see some activity from those cells. Now, that's the superior medial border. Looking at the margin between the putamen and the globus pallidus externus is external medullary lamina, and then internal to that, between the GPE and GPI, is the internal medullary lamina. And those are important structures also because we will look for those as we cross using microelectrode recordings. You're looking for the silence of those areas as you pass from one nucleus to the other. Of course, we also have the external capsule on the external surface of the putamen. Talk about some of the other structures. Inferiorly, the target that we really look for in the posterior lateral portion of the GPI, which we target, in the inferior part of the GPI, which we target, is going to be the optic tract. So the optic tract forms the inferior limit, especially where we're putting electrodes, and that's something we look for both electrophysiologically and with the stimulation side of things. So microelectrode guided anatomy. So as you all have hopefully seen in the operating room, as we're targeting different structures, we can put a microelectrode, which is a microwire, down and advance it slowly through the trajectory, or the last 15 to 20 millimeters of our trajectory, in order to define the electrophysiological activity and the spiking activity of the different cells that microelectrode might encounter. And that's really the scope of another talk to get into extensive detail about these firing activities and where they come from. But what I did want to emphasize is that you see a clear difference between when you pass an electrode through GPE, as you get through the internal medullary lamina, which is the limiting extent between the GPE and GPI, and then once you get into the GPI, you've got a much higher frequency and a regular level of activity and spiking activity. If you go further, you can get into the optic tract, and that should be silent, although you can get evoked potentials with visual stimulation. So we've gone through the atlas coordinates. We've gone through the anatomic landmarks and anatomic borders of the structure of the globus pallidus. We've gone through the briefly reviewed microelectrode recordings. And then the last thing that we use as neurosurgeons is looking at the side effects of stimulation. And understanding everything that I just told you would really help you understand the side effects of stimulation. So when you are trying to target this is the GPI in this case, because we don't target GPE with striatum, you can stimulate or pass a current through your electrode and look at what the side effects are. In this case, there's really only two eloquent structures when we're targeting GPI, which we saw on the gross anatomy and which we're looking for the side effects of stimulation. And that's going to include the corticospinal tract, which will be medial and posterior. So if our electrode is too medial, you'd slide into the posterior limb intimal capsule, and if it's too posterior as well, you would get into the posterior limb intimal capsule, and that's going to give you corticospinal tract activation and give you contralateral contractures. And like we showed, being too inferior will give visual phenomena due to stimulation of the optic nerve. Everything else is a little bit silent, and what we mean by neurosurgeons, when neurosurgeons say it's silent, it just means we don't know exactly how to test the effect. Obviously, there's something going on within that structure. We just don't have sensitive enough tests, especially in the operating room, to detect that.
You mean optic tract or optic nerve?
Optic nerve. I said, sorry, it should be optic tract. Yes, it should be optic nerve, not optic tract. The other thing to appreciate, we spend a lot of time learning about the homunculus in the somatosensory and the motor cortex. And really what we're starting to appreciate and learn is that there's somatotopy almost within every structure that we have. And I just wanted to show, this is just one example, and there's other examples depending on what reference you look at. But there's a somatotopy within the GPI, as well as the striatum, mapping different structures to different parts of these subcortical structures. And in this case, you can see how the lower limb is represented in a more posterior aspect than the upper limb. This is another representation where you can see posterior and anterior. Lower limb is more posteriorly represented versus upper limb and orofacial representation in the sagittal plane. So it's important to appreciate that there is somatotopy, and that at this point doesn't really influence greatly how we do our surgeries, but I can see in not too distant future where people may become more innovative with how we place these electrodes and try and target specifically different areas for treatment of different diseases. So I'm going to switch gears so away from the globus pallidus and look at the subthalamic nucleus. And again, starting with atlas coordinates. These are the classic atlas coordinates, really advocated by Dr. Benabid in France. And these are relatives to the ACPC again. So these are the reason why ACPC has been stressed again, remember, is because we didn't have the imaging technology originally to see and have direct targeting based on anatomic landmark. But it's a really good starting point. And I just heard someone say that in 95% of cases, that's exactly where you need to be. I'm not sure 95% is exactly as high as I would suspect, but it's a very good starting point in most cases. There's been other reference frames that have been advocated, and that's using other adjacent landmarks, including the red nucleus and targeting where you want to put your electrode relative to the red nucleus. So most neurosurgeons are using multiple indirect targeting methods, such as those described here. And then we go to direct targeting, which is based on anatomical imaging. So many different ways to visualize and many different representations of where the subthalamic nucleus is. And first of all, I'll start with the coronal picture of what's going on. And so this is coronal, thalamus, third ventricle, and lateral ventricle. And if you look under the thalamus, there is the zona incerta, and below the zona incerta is the subthalamic nucleus. The subthalamic nucleus is an ovoid nucleus. It sits at an angle, and you can see here, the angle can vary depending on what patient you're treating. It could vary from as little as a 15 degree off of vertical up to 57 degrees off of vertical, with an average of about 40 degrees. So you can see it's ovoid. We want to approach it from an angle so we can get as much of the nucleus as possible. But no matter what plane you look at it, it has that obliquity to it. So this is looking at it in an axial. So this, we're looking at, if we're in radiographic format, at the right side. And we've got the red nucleus here, and you have the subthalamic nucleus here, again in an oblique position with adjacent structures around it. If we look at the sagittal plane, again, it's oblique in that plane as well, and so this is anterior and that's posterior, and you have, you can see the structure and its relationship, again, relative to the thalamus with the zona incerta and Farrell's field, and we'll look at that a little more. Subthalamic nucleus, and sitting below the subthalamic nucleus is the fourth part of the globus pallidus, which which I refer to as substantia nigra. And those relationships are really, really important relationships. So you have internal capsule. Laterally, you have internal capsule laterally, substantia nigra inferiorly, and you could see because we're in the subthalamic nucleus and because we're in the brainstem, just adjacent to the red nucleus. If we're too medial, we'll be in the region of the third cranial nerve. We'll talk about side effects in just a moment. So, from a microelectrode standpoint, really, you can start to appreciate once you look at images such as the one we saw on the last slide, that your trajectory and what you see on microelectrode recordings will really vary depending on your precise trajectory and what structures you cross. So in many cases, we will have a trajectory that will come down from an anterior to posterior direction and a lateral to medial direction. And we will, in most cases, cross the thalamus, in which we'll see bursts, small bursts of activity in a background of relatively low power background. What we see then is, as we exit the thalamus and we enter Farrell's field H2, you enter the subthalamic nucleus, and you see a much higher frequency and regular it's regular but irregular spiking activity. And depending on how you analyze these, you can look at whether you're looking at a single unit, 2 units, or multiple units. One thing that this slide does not show very well, but is very apparent when you're actually doing the intraoperative recording, is that the background in the subthalamic nucleus is actually a much higher power, and you can often see that change in the background power of electrophysiological activity before you start seeing that spiking activity. Once you leave the subthalamic nucleus, and hopefully you're getting about at least a 4 millimeter, but up to a 6 millimeter penetration through the subthalamic nucleus, you get a brief period of silence before you enter the substantia nigra, which is much higher frequency and much more regular in its pattern. So again, as we discussed before, and this will bring back the anatomic landmarks that that I briefly reviewed. Once you get the electrode in there, you can stimulate the subthalamic nucleus, and by stimulating it, you elicit or recall the anatomy of all the adjacent structures. So remember, as I said, the lateral margin of the lateral margin of the subthalamic nucleus is the internal capsule. So if you activate the internal capsule, that can, and if you're too lateral and have your electrode in there, activation of the internal capsule will result in dysarthria due to oral facial contractions. It can cause contralateral contractions. It can also, by activation of frontal eye field projections to the brainstem, result in conjugate gaze deviation. On the contrary, or in the opposite direction, if you're too medial, you have the cranial nerve 3 exiting through the anterior midbrain, and so activation of or placement of electrode too medial within the subthalamic nucleus or medial to the subthalamic nucleus can result in diplopia. And yeah, so Colin and I just exchanged a battery on a patient yesterday who had a subthalamic nucleus electrode, and we programmed him back to his previous setting, which was at 3 volts, and the patient was complaining of diplopia. And so what we did is just went back down on the voltage, just down to 2.5 volts, and his diplopia was better, and he was still getting a beneficial effect with respect to his Parkinson's disease. So these are real-life experiences that we deal with. So what I didn't mention on the gross anatomy slide, in the posterior margin, the medial lemniscus is coming up or rising from the brainstem up to the thalamus, just posteriorly to the subthalamic nucleus. So a posterior placement of your electrode can cause activation or recruitment of medial lemniscus and result in paresthesias. And too anterior, it could be in sort of peduncle, could cause contralateral contractions, although often you don't get an effect. Too inferior, so remember I said you get a brief silent phase as you go from the subthalamic nucleus to the substantia nigra. But if you activate the substantia nigra, which you could easily do, sometimes it can be confusing to differentiate between the subthalamic nucleus and substantia nigra, it can result in affective changes even intraoperatively. And again, continuing with that concept that I presented with the GPI about somatotopy in deep structures. So even the subthalamic nucleus had, despite its small size, only being about 6 to 8 millimeters in size, in its greatest dimension, there's a somatotopy to it. And you can look at different projections from different parts of the brain, including supplementary motor area, primary motor area, and looking at it, so that's, as it indicates here, medial and dorsal. You have an inverted homunculus going bilaterally, controlling different aspects. In deep brain stimulation, the theoretical target is to get into the dorsolateral aspect of the subthalamic nucleus, although it's such a small structure, I think it's, most people really just want to get it through the subthalamic nucleus. Okay, so that's all the structures, and like I said, you can spend all day trying to learn all the structures, but really what's important is how everything interconnects with each other. And so the first aspect of the connectivity is to understand what the afferents are to this subcortical loop. And the afferents are those from the motor cortex, supplementary motor area, and premotor cortex. And what we learn classically in textbooks is that the cortices all project to the striatum, and the striatum is the recipient of the afferents to the basal ganglia circuits, and these are glutamatergic in nature. So it's an excitatory input to the basal ganglia or subcortical circuits. Unfortunately, these slides are not working here. That's very nice. Good picture too. So I'm doing this from top and bottom, and then we'll go in between. The efferents, the primary efferents from the basal ganglia, so the last aspect of the basal ganglia to send signals out is going to be the GPI. So it's the GPI and the substantia nigra pars reticulata are the major efferents, and they send their efferents to the thalamus, which remember is not officially part of the basal ganglia. These are GABAergic projections, and they project from the GPI and the substantia nigra via the lenticular fasciculus and the antilenticularis, which surround the subthalamic nucleus, and hopefully we'll see a good image of that. But these are the critical output tracts from the basal ganglia to the thalamus, and that is also GABAergic in nature. These are the major outflow tracts of the basal ganglion, the globus pallidus, to the thalamus. These are GABAergic, and there's two major pathways, the lenticular fasciculus as well as the ancillenticularis. And as you can see, they really hug the subthalamic nucleus and are in close proximity to it, and they are feeding into the motor system, or the motor nuclei of the thalamus. So now that we have our afferents and efferents, we can look within the circuit. What I wanted to emphasize is that the GPI, or the major output from the globus pallidus, so the subcortical circuit, inhibits excitatory thalamocortical projections. So there's an inhibition. So now looking at the two pathways that we all learned about, the direct pathway is a direct GABAergic projection from the major afferent recipient to the major efferent source. So what you end up having is a GABAergic projection here, and it results in increased excitatory thalamocortical activity, or it causes disinhibition of those thalamocortical projections. So the net effect is to excite the cortex. So it's a positive feedback. The indirect pathway has multiple stops along the way. Instead of going directly from one point to the other, from the striatum to the globus pallidus internus, there's a projection to the globus pallidus externus, down to the subthalamic nucleus, both of which are GABAergic, and then the subthalamic nucleus, as we all know, is glutamatergic to the GPI. The net effect of this indirect pathway is to inhibit the globus pallidus. Inhibit. Is to stimulate the globus pallidus, which inhibits the thalamus and inhibits the thalamocortical projections. So the net effect is inhibitory on the thalamocortical circuitry. Next slide. Now we get to the substantia nigra, and I think once you separate those two, then you can think about the effect of the substantia nigra. And substantia nigra has dopaminergic projections to the striatum, and the effects of dopamine is dependent upon the receptor which it lands upon. The D1 receptor type is excitatory and feeds into the direct pathway, so it promotes disinhibition of the direct pathway and results in a net positive increase in thalamocortical activity. D2 receptor type is inhibitory, and it ends up inhibiting the indirect pathway. The indirect pathway, as I said, is inhibiting the excitatory thalamocortical activity, so you're inhibiting the inhibition. Again, this pathway also ends up in a the net effect of the substantia nigra input on both indirect and indirect ultimately is to promote the activity of the excitatory thalamocortical projections. So if we now look at Parkinson's disease, if we think about the fact that this substantia nigra is being inhibited or is deteriorating, and so the net excitatory influence on the striatum is the net excitatory influence on the entire subcortical pathway is being depleted. You have decreased activity of the thalamocortical projections, so decreased excitatory thalamocortical projections. So what we can do is, in the targets that we go to are the GPI, which we said is inhibiting those thalamocortical projections. So if we stimulate that and interrupt that pathway, we can hopefully disinhibit the thalamus and let those excitatory thalamocortical projections fire more frequently and restore some normalcy. Or go to the subthalamic nucleus, which becomes hyperactive, and stimulate that region, and then again result in a net increase in excitatory thalamocortical pathways or thalamocortical activity. My main point in showing this slide is we're not, and my main point that I want to make in this entire talk is we're not treating a single nucleus. It's not that we're changing something in that one region, we're changing the entire network. Next. Yes.
For the residents, if you stimulate the GPI, you're really favoring one part of Parkinson's in contrast to stimulating the subthalamic nucleus, in contrast to treating bradykinesia versus resting tremors.
Yeah.
The lesion you select is specific to the clinical manifestations of the patient. That's more a question than
a little bit. So, in the vast majority of cases, we will target the subthalamic nucleus. In the vast majority of cases, we target the subthalamic. So the question is how we select our target for stimulation. In most cases, we target the subthalamic nucleus because that's mostly because that's the trend right now. It's very good at treating the symptoms, like you said, of bradykinesia, of treating the tremor, and it's also fairly good at treating the dyskinesias. Cases in which we will treat the closed palatal internus are going to be in patients who are more worried about side effects. As Dr. DeSales mentioned, the subthalamic nucleus, we get far more side effects. So in older patients who might have impaired cognition, or they might have, or if there's a history of possible psychiatric disease, depression, we'd be more inclined to treat the GPI. The other reason we would treat the GPI is if someone has a very strong history of dyskinesias, and dyskinesias were a primary target of treatment, then we might favor the GPI over the subthalamic nucleus as well. Yeah.
Does the substantia nigra pars reticulata have any dopaminergic projections to the thalamus, or is it mostly GABAergic?
Just GABA.
Just GABA.
I just want to clarify, if we go back to that previous slide, when you're treating Parkinson's disease and you're targeting the STN, the subthalamic nucleus, and it's deep brain stimulation, but you're actually causing a lesion there. Is that correct? Because the STN, right, is positive on the GPI, and the GPI is negative on the thalamus. So if you cause...
So STN normally activates the GPI.
Right.
So if you take away, so we'll talk about what exactly happens
Yeah.
later, but if you take away that excitatory input to the GPI, that means you're reducing the inhibitory effect of the GPI on the thalamus, which ultimately promotes the excitatory thalamus cortical projection.
So I just want to clarify that you're essentially causing a lesion of the STN,
it's
not stimulating the STN.
The belief is that you're causing a lesion. It's lesion via stimulation.
Okay. Thank you.
Next slide. So we've talked a lot about, so what you learn about are the direct and indirect pathways, and if you actually look amongst functional neurosurgeons who are really interested in it, and then scientists who are very interested in it, it's not just a direct and indirect pathway. There are more pathways than that. So really there's a lot of interest in what we call the hyperdirect pathway now, which is the cortex projecting directly to the subthalamic nucleus. And we think that may be a very critical part of the network. In that, you can imagine if this is excitatory and excitatory, this really causes a major inhibitory influence on the thalamus. And so the thought is that this might be a major part of the Parkinson's disease pathway, that there is this abnormal super excitatory effect coming through that pathway. And there's different time courses of how these things get through. So you can imagine the direct pathway we thought was the quicker pathway than the indirect pathway because there's fewer synapses. Indirect took a long time. So direct and indirect in terms of time, you can clearly see a differentiation. If you look at the hyperdirect, there's even one less synapse. And so you can see a modulatory effect so that all these different networks are working together to modulate at a subcortical level your motor output, and they're all feeding back into each other. So inhibition followed by disinhibition followed by inhibition once again. And now there's evidence coming out that it's not just this hyperdirect pathway, but there's hyperdirect pathways from SMA to the subthalamic nucleus, and that this is a network that is really important in modulating our overall ability to stop. And so if you look at, and it's amazing how many fields this crosses, but in the field of addiction, there's a strong interest in our ability to stop activities. In the field of Parkinson's disease, this concept of being overly stopped. And you can look in many different diseases where there's this emerging interest in this stopping phenomenon and a pathological ability to stop or not stop.
Are these GABA pathways, or are they?
These are excitatory.
Okay, and the hyper direct pathway is
It's good.
And so just I brought this slide back up because, you know, I brought this up in the context of the circuits, but really want to call to your attention that even in this slide we're talking about direct motor projections to the subthalamic nucleus, although that's not what we're usually talking about, but that probably is going to emerge as an important one. Next slide. And again, this is to emphasize that, you know, we're working at a network level, and historically, if you look at the treatment of movement disorder, this is Parkinson's disease. There's 11 different places where we've targeted treatment for Parkinson's disease, starting from the cortex to the corona radiata to the internal capsule, different parts of the thalamus, subthalamic nucleus, locus pallidus, the peduncles, down to the spinal cord. So it's a huge network, and you can interfere with this network at any level. It just demands an understanding of the circuit. So, next slide. And push next slide. So, and again, emphasizing the need to understand the circuit is when we put this large electrode into the subthalamic nucleus, and Justin, this was getting at your question. You said we're stimulating the subthalamic nucleus, and that's causing a lesion of the subthalamic nucleus. We actually have no idea what we're doing because we're putting this massive electrode in this tiny little target, and you've got all these other pathways all around it. You've got these really important tracks from the GPI to the thalamus, to the lenticular fasciculus. You have antillenticularis. You have zona incerta right above the subthalamic nucleus. You have cortical, so you have the direct cortical subthalamic projection. It's a really highly rich network of fibers passing in every direction possible. And so next slide. So this is really the technology that I think is starting to give us some insight into what we're doing. And I don't know if any of you are aware of this, but this was a group up at Stanford who they're using optogenetic studies, and what they do is they genetically modify animals to express optically sensitive channels using cell type specific promoters. So they engineer these animals to have different subsets of neurons different subsets of neurons to express different channels. And they can use different types of channels. So they have the channel rhodopsins, which if they're expressed, can be light activated and they cause depolarization, so it's activation. And they have halorhodopsins, which encode light activated chloride pumps, and they cause hyperpolarization. So now, for the first time, instead of just passing a current blindly into the brain, what you can do is dissect it. You could say, all right, we're going to express this channel in a specific target and shine a specific wavelength of light so we know exactly where we're causing our electrophysiological effect. And they did this very thoroughly through in rodents, in the Parkinson's disease model. And I'm not going to show you all the results. But what they did was, in this case, they the first study they did was to actually express these in subthalamic nucleus neurons. And they showed that if you inhibit subthalamic nucleus neurons, so you have them expressing the halorhodopsin, shine light on it, you hyperpolarize these cells so they're not firing, you get no beneficial effects that you'd expect from stimulation. So it's not from direct effects on the subthalamic nucleus, which has been the prevailing theory from the outset. They showed, to the contrary, if you put the channel rhodopsins and you activate it with light and you cause increased subthalamic nucleus activity, you worsen the animal. So increased activity of the subthalamic nucleus definitely is worse. The next thing they did is, okay, they said, well, let's not look at subthalamic nucleus, let's look at the projection neurons. So they, in this case, what they've done is you can't quite see it here, but what they've done is they've labeled or expressed the channel rhodopsin specifically in cells that are, or in the projection axons, or the pathways that are leading up to the subthalamic nucleus, and they determined the effect of high-frequency stimulations as high-frequency light emission versus low-frequency light emission. And what they were able to show is that when you do high-frequency depolarizations of those afferent axons to the subthalamic nucleus, this is a behavioral test, you see a significant improvement in the behavioral symptoms of these rodents. Low-frequency stimulation does the opposite and makes them worse. And you can, and at the same time, they did electrophysiological monitoring to confirm that they were actually causing the changes that they wanted to make. Next slide. And then, I don't know why they did this, but they must have done a lot of things and only reported this and made it look really good. But they said, well, which afferents are actually the most important ones? And they said, well, let's look at layer 5 projection neurons, pyramidal neurons from the primary motor cortex. What happens if we directly depolarize those cell bodies in the primary motor cortex? What happens to these animals? And sure enough, it's the afferents, or at least those afferents mimic the same behavioral response. That if they depolarize those motor cortex neurons at the cortex and measure activity in the subthalamic nucleus, they get those beneficial effects. So this is, a very elegant way, instead of passing blind current into this region, to very specifically deliver electrical modulation to an area of interest. And they just reported, I haven't actually looked at the manuscript, but actually I don't think it was them, it was another group, but using lentivirus to specifically transfect the population, a target population within a primate, and then modulate activity, so in a primate model. So who knows, this is early on, but this might be something that we'll be looking forward to, where we actually create much more specific modulation using viral vectors to select our targets, and then using optos to stimulate targets of interest. This is really early, but it beats just gross electrical stimulation, because you won't get all the side effects, but then you have to think about the risks of viral treatments.
The photostimulation comes from a depth electrode.
It's an opto, it's a depth, but it's not.
Yeah.
So, yes.
I was just wondering, do you know what promoter you use for STM?
I don't know.
It's probably like hydroxydopamine for the vision.
Yeah, I don't know specifically. So despite learning direct and indirect having a very simple pathway, you see it's actually a very complex pathway. Cortex is projecting everywhere. GPI is getting inputs from everywhere. And then besides all these connections, we have other pathways passing right by all these really critical targets. So it's a really complex environment. Next slide. I might not be able to do it. I'm going to just go through this really quickly. So part 2, this is a complete change from what we talked about before, just thalamic anatomy. And this is something that as a resident always plagued me, and I can never really get really understand thalamic anatomy. I think hopefully I'll just go over this very quickly and elucidate some of the structure of the thalamus. So the thalamus, if you think of it as 3 major nuclear groups, there's an anterior group, medial group, and lateral group. And actually the lateral group is the only one that's a group, because the anterior and medial group are single nuclei. Next slide. The intramedullary lamina is what separates all these. There's a lamina that bifurcates anteriorly. The anterior portion is the anterior nucleus. The medial portion is the medial group. And then the lateral portion has all the other nuclei. Within the intermedullary lamina are other nuclei, including the central median nucleus, which, again, as we mentioned earlier, is now being thought of as part of the basal ganglia complex. Next slide. So as I said, the anterior division has a single nucleus, which is the anterior nucleus. The medial division includes the dorsomedial nucleus. The lateral division has many, many nuclei, divided into a ventral tier and a dorsal tier. The ventral tier should be pretty easy for us to remember, because it's made up of the motor and sensory nuclei, and then our other special senses, so auditory and visual. So you have ventral anterior, ventral lateral nucleus, which are our motor nuclei. The ventral posterior, which is VPL and VPM, which are our sensory nuclei. We'll talk about it a little more. And then medial nucleus and lateral nucleus. And then the dorsal tier has a very small lateral dorsal and lateral posterior, which we hear very little about, and then obviously pulvinar, which is the largest nucleus, associated nucleus. Pulvinar and dorsal medial being our largest nuclei. Those are the associated nuclei. Next one.
Could you show them approximately VIM? The VIM?
Oh, yeah. So VIM, and that's a little bit of a confusion because everything is a different nomenclature. VIM is primarily, so we think of VIM as lying between ventrolateral nucleus and the VPL or VPM, but my understanding, my interpretation, it's really posterior margin of the ventrolateral nucleus is how I interpret it.
I don't know where it is, because everybody describes it. Liz Berger describes it different than the.
Yeah, I think based on, And we'll talk about it. I'll tell you why I think the VIM is actually part of the ventral lateral nucleus. It's primarily because it is the VIM receives projections from the cerebellothalamic tract, and cerebellothalamic is part of the motor pathway. Ventral lateral nucleus is a motor thalamic nucleus. So my interpretation and my understanding is it really lies just in between these two, but it's the posterior margin of the ventral lateral nucleus. So thalamic neurons, most of them are projection neurons. There are also inhibitory interneurons, which are all GABAergic. There's relay and association nuclei. Next slide. You can think about each nucleus with respect to its inputs and its outputs, and we know all these very well. I'll show them in the next slide. And just like every other structure has a somatotopy, there's an ability, you can really start to divide up these nuclei based on their projections. And Mark has just left the room, but Mark is working on a study, and it's been done before, but you can map out, using diffusion tensor imaging, which is tractography using MRI, we can now try and look at the relationship of where the major projections from different parts of the thalamus are going in order to create nuclear maps of the thalamus, and hopefully we can use that to target DBS. Next slide. Just going through the relative relationships of these, I'm going to go through each of these slices in this format. I feel like I got this from UCLA when I was in medical school. Does that look familiar?
Yeah.
It does look familiar.
I've been using these for a long time.
Kind of like abdominal pain when you look at it.
So
It's like an Arnie Scheibel
yeah. So if you look really, it's amazing how concordant this drawing is, which is from a neuroanatomy textbook with this histological sections. But anterior nucleus sits anteriorly and superiorly, and there's always a nubbin going into the lateral ventricle, which helps to identify this as a target for deep brain stimulation. And then there's the intellomedular lamina separating it from the ventral lateral nuclei, which is the ventral anterior nucleus. Next slide. And if we look at that anterior nuclear group, it's part of Pape's circuit, which you should all know quite well. It has its afferents coming from the mammillary body, and then efferents, the cingulate gyrus. And those efferents, this is something which I rarely actually see in a textbook, where you always hear that the anterior nucleus goes to the cingulate gyrus, but rarely do they say how does it go there, and it goes through the anterior limb and internal capsule. Next slide. So if we take a step back now, a further back slide, so we still have our intramedullary lamina, anterior nucleus sitting on top, and now you see your medial nuclear root, dorsal medial nucleus, and now we get to the ventral lateral nucleus, which is our motor nucleus to the thalamus. Next slide. So the ventral lateral group, which is the motor nuclei, and basically the major one, and this is what we were getting to before, the major input that is of concern to us neurosurgically, besides the basic input, is the cerebellar nuclei projection to the ventral lateral nucleus of the thalamus. And you can see this crossing over and landing in the VIM nucleus. Depends on where you look. I'll say VIM nucleus or the VL nucleus. But it's the posterior aspect of that. And that's what we're targeting when we're targeting tremors, is we're trying to hit those projection fibers as they're ascending to the cortex. Next slide. Another slide back, we have our medial dorsal group and the lateral dorsal group. Now we're getting into, more interestingly, the VPL and VPN. And those are our primary sensory. So we know the trigeminal nerve, trigeminal nucleus will project to the VPM, which is our facial representation, and VPL is the rest of the body. Next slide. Sorry, the dorsal medial nucleus was also on that slide. And this is the second largest thalamic nucleus after the pulvinar. It's the secondary integration nucleus. Pulvinar will really integrate from the parietal occipital temporal regions, whereas the dorsal medial nucleus will really integrate through the medial temporal lobe, but also the frontal lobes, the prefrontal areas, and association nucleus. Just means we don't know what it does yet. What's that?
But you can make it up. Right?
Yeah. Next slide.
Do it all the time.
So the medial nuclear group, this is important in terms of stimulation. So because it's involved in that prefrontal area and frontal syndromes, stimulation of this area, will result in anxiety and dread, and also can be, remember, it's also involved with medial temporal structures, memory loss, and can result in Wernicke-Korsakoff syndrome. Hopefully, okay, next slide. The dorsolateral nucleus, I'll skip. The ventrobasal complex. So this is again VPL and VPM, our primary sensory relay nuclei. As before, there's a somatotopic organization of this nucleus with, and I just remember that it's opposite of what the primary motor cortex is. So if you think that the primary motor cortex homunculus with face and arms on the outside and legs on the inside, thalamus is reversed. So face and arms are towards the medial aspect, and the legs and lower extremities are towards the outside. So that's an important relationship to remember. And then also understand that there's a very specific projection pattern of where different parts of this nucleus project to different parts of the sensory, primary sensory cortex, and as we know, there's different areas of that. Next slide. And then the pulvinar. Pulvinar, medial geniculate, lateral geniculate, you can see all in one cross-section.
Hello.
Yeah. Oh,
Sorry.
oh, next slide. Sorry, I'm going quickly. Pulvinar is the largest integrated or associative nuclei, integrates visual, auditory, and somatostatic input. And injury of that can really result in pain, syndromes, and really refractory pain syndromes.
Just as a side, what disease that is emerging in the last decade that affects the pulvinar primarily? Prion disease.
The question is, what disease primarily affects the pulvinar and its prion disease?
It's usually bilateral. They itch, they hurt. They may present that way. They don't present with dementia.
And geniculate, maybe we'll leave that. We'll stop there. Yeah, I think I'll just stop there.
Do you have anything to say about the centromedian and the putamen? Is that still? It has the largest connection.
Right.
I forget which way it's going though. Is it from the pulvinar to the centromedian?
I think it's projecting.
Thalamic.
It's projecting out from the thalamus to the putamen.
The rostral intralaminar nucleus. It's the most important for us.
The rostral.
Yeah, the projections from the ascending reticular activating system projects to that. It's always involved in wakefulness and everything like that.
But yes, the reticular nuclei of the thalamus. Yeah. Right.
You understood the importance of what he said about the interthalamic laminar nuclei. That's basically it, the centromedian and the perifascicular nuclei are part of that. So you think of the centromedian, you think of perifascicular. Why do they call it perifascicular? Because it is the posterior part of the centromedian that has passing through it some fiber tracts that come from what? Mammillary body to what? Tractus retroflexus. And that's why they call it perifascicular. It's projections from that to the venular nucleus, and it projects through the posterior part of the centromedian, and for some reason it's what you were saying. It's not, these aren't really defined areas. They're all connected.
So I apologize that this is sort of anatomical and structural, but really it's supposed to give you, hopefully the thalamus will help you understand the organization of the thalamus, but the subsequent talks will be much more clinical and relevant, and they'll rely on the basic understanding of this anatomy.
It's excellent. Just excellent.
Any questions?